All right, hi guys. Today we are going to cover antimycobacterial agents. Mycobacteria are a very specific type of bacterium, and mycobacteria behave a little bit differently than other bacteria. One of the major differences is that they are very slow to grow and divide and spread. Um, Mycobacteria tend to form these lesions, these slow-growing granulomatous lesions that, as they slowly grow in the body, they cause tissue destruction in the area that they are in. We're really going to focus on Mycobacterium tuberculosis in this lecture. Mycobacterium tuberculosis is the most common mycobacterial infection worldwide, and it has its own very specific treatment regimen. There are some drugs that are specific to just tuberculosis, and again, it has a very specific regimen that we're going to focus on. Other non-tuberculoid mycobacterial infections are increasing in frequency, unfortunately. So we are seeing, more and more Mycobacterium avium intracellular, or Mycobacterium abscessus, Mycobacterium leprae. So there are other mycobacterial infections, and again, they are increasing in number. However, we don't have drugs that are designed specifically just to treat those mycobacteria or mycobacterium. We use our other traditional antibiotics to treat those other mycobacterial infections. And the treatment varies based on the agent and the agent's susceptibility. For example, we can use some macrolide antibiotics, some rifamycins, which we'll talk about a rifamycin antibiotic today. Aminoglycosides can be used. So just depending on the specific mycobacterial agent, we'll use different antibiotics. Again, today we're going to focus on Mycobacterium tuberculosis and the very specific treatment that we utilize for it. So Mycobacterium tuberculosis can cause latent tuberculosis infection, or it can cause the actual active disease tuberculosis. So latent tuberculosis infection, which you see up top here, is when somebody is infected with Mycobacterium tuberculosis, but they don't have any signs and symptoms of the disease. So the bacterium is present, but we're not seeing a lot of tissue destruction that's causing active signs and symptoms. There are estimates that up to 25% of the world's population is infected with Mycobacterium tuberculosis. That is massive. Now, most of this is not in the United States. We do see much higher levels of latent tuberculosis infection in some other countries. But it is very common. Latent tuberculosis infection is very common. Especially in some subpopulations of people, people who get clustered together or crowded together, which we'll talk about a little bit later. So we do treat latent tuberculosis infection. Even if there are no signs and symptoms present, we treat it. And we treat it for a very long period of time. Tuberculosis in general is treated for a very long period of time. We treat latent tuberculosis infection with Isoniazid, which is one of the traditional anti-tuberculosis drugs. And Isoniazid is given for 9 months. We can also use, there's an alternative treatment regimen that lasts for 3 months instead, or for 12 weeks. And this is once weekly high-dose isoniazid along with rifapentine, which is a rifamycin drug, but rifapentine, and this is given for 12 weeks. So first line, again, is isoniazid for 9 months. Second line option would be, what you see here for 12 weeks. This would be a good option if, say, you couldn't treat the patient for 9 months, or if you had concerns with the patient being able to remain compliant for that long, then maybe that 12-week option would be better. Tuberculosis is the actual active disease. So when somebody is infected with Mycobacterium tuberculosis, that Mycobacterium tuberculosis is causing tissue destruction, and this is causing actual signs and symptoms in the patient. Active, tuberculosis is the leading infectious cause of death worldwide. Again, very, very common. Tuberculosis is a huge issue. Again, especially in some other, third world countries, where we don't see as much access to treatment and where we see more overcrowding in small areas. When we look at active tuberculosis, the first line treatment includes a combination of 4 drugs. We'll talk about this a lot, but those 4 first line drugs include Isoniazid, Rifampin, Ethambutol, and Pyrazinamide. Treatment for drug susceptible, so not resistant, but drug susceptible tuberculosis lasts for a total of 6 months. We'll see that the preferred treatment is all 4 of those drugs for the first 2 months, and then we continue just 2 of them for another 4 months. So a total of 6 months. Treatment for multi-drug resistant tuberculosis can last about 2 years. Okay, again, very, very long treatment. And this has to do with the way that Mycobacterium behaves. Remember, we said it's very slow growing. And it does tend to form little protected capsules, if you will, little protected areas. So it is a lot harder to treat than, traditional bacteria. Second line agents are less effective and more toxic. So our first line drugs are highly preferred. The only time when we would use these second line agents is, again, when we have resistant TB, resistant tuberculosis, or when, for whatever reason, the first line agents are not tolerated. So here you can see the current recommended first line therapy for tuberculosis infection includes 2 phases. The intensive phase for the first 2 months, and then the continuation phase for the next 4 months. Again, for a total of 6 months of therapy. So the intensive phase includes taking all 4 drugs, Isoniazid, Rifampin, Pyrazinamide, and Ethambutol. So we take all 4 drugs for these first 2 months, and then for the remaining 4 months of therapy, we're taking just the 2 key anti-tuberculosis drugs, Isoniazid and Rifampin. So again, you see those are continued for another 4 months for a total 6 months of therapy. The way you can remember this is 4 drugs for 2 months, then 2 drugs for 4 months. Okay, all 4 drugs for the first 2 months, and then we continue Isoniazid and Rifampin for the remainder of therapy. And I'll talk to you a little bit. Sometimes we can decrease the number of drugs down to the 2 a little bit earlier than 2 months. depending on when we get the culture and sensitivity report back, but I'll talk to you guys about that in a minute. All right, so this is how we treat most tuberculosis, right? How we treat drug-susceptible tuberculosis. Multi-drug resistant TB is tuberculosis that is resistant to those two key antibiotics that we use. So if we have tuberculosis that shows it's resistant to Isoniazid and Rifampin, we call that multi-drug resistant TB. And this is highly problematic because those are the key agents we have to fight tuberculosis. Treatment for multi-drug resistant tuberculosis can include an aminoglycoside, a fluoroquinolone, whatever active first-line agents we have. So out of those 4 drugs, whatever ones are shown to be active, and then we combine that with an additional antibiotic. The specific one that we utilize depends on the tuberculosis, what the culture and sensitivity shows. However, these agents are necessary for sure. The aminoglycoside antibiotic that we use can be streptomycin or amikacin. The fluoroquinolone antibiotic that we use can be levofloxacin or moxifloxacin. So speaking of resistance is very, very problematic in tuberculosis. Tuberculosis is hard to treat as it is. As you can see, we give a large number of drugs for a very long period of time. Tuberculosis is possibly fatal. Again, the leading cause of infectious death worldwide. So making sure that we treat the tuberculosis and we do not stimulate resistance is very important. Multi-drug therapy is required to prevent resistance from developing. We never give just one drug to treat tuberculosis, as you can see based off of these regimens. Also, the full course of antibiotic treatment is necessary. The full regimen must be completed. Symptoms might improve after a few weeks of therapy. So, the patient might be on therapy for a month and then they feel better, but they need to continue therapy for the remainder of the period, right? The full time that they're supposed to be taking those antibiotics. Because of that, very frequently, or typically when we're treating tuberculosis, we use something called directly observed therapy. Okay, DOT, directly observed therapy. Most health departments offer this. So what this is the patient goes into the health department daily and they are observed taking the medication. So we don't just prescribe 3 months of the antibiotics and send the patient on their way with them, because again, it's incredibly important to ensure that the patient follows through with the full course of therapy. Compliance is necessary, and we don't leave that up to chance. We don't just hope that they're compliant. We monitor it very, very closely. I'll talk about this with you guys a little bit more in a second. But again, it is recommended that patients do directly observed therapy where they're observed taking the antibiotic every day. That way, if the patient doesn't take it, we know immediately and we can follow up with that. So these charts, this chart and on the next slide, these are taken from the guidelines. one thing or a couple things that I want to point out, remember, we're talking about treating active tuberculosis, not latent tuberculosis infection. So this is treating active tuberculosis. We're talking about treating drug-susceptible tuberculosis, right? Remember, it's different if it's multi-drug resistant. Also, we're talking about treating pulmonary tuberculosis, which is the most common. This is typically what we're going to be treating is pulmonary tuberculosis. And this is in HIV uninfected adults. Right? If you're treating a patient who has both HIV and tuberculosis, there are specific guidelines for that. Right? So anytime there's kind of a caveat, if it's multi-drug resistant, if it's non-pulmonary TB, if your patient's also HIV infected, there are specific guidelines for each of those situations. These are the traditional guidelines for your, run-of-the-mill, if you will, tuberculosis. So, again, we've already kind of mentioned this, but here up top is our preferred therapy for patients with newly diagnosed pulmonary tuberculosis. One thing that we haven't talked about on here yet is, well, first off, all four agents, Isoniazid, Rifampin, Pyrazinamide, and Ethambutol, that they are given, all four are given 7 days a week for 8 weeks, right? 2 months. So they're given daily for 2 months. Then just Isoniazid and Rifampin are given daily for 126 doses, right? Or another 4 months. So 4 for 2, 2 for 4. Now, what I haven't mentioned yet is that you can, instead of giving this daily, right, 7 days a week, you can give it 5 days a week, right? So this is for the full course of therapy. You give all 4 drugs daily, 5 days a week for 2 months. Then you give the 2 drugs 5 days a week for another 18 weeks, right? Or another 4 months. So there are no studies that are specifically showing or comparing 5 days a week therapy versus 7 days a week therapy, but the 5 day a week therapy has been used extensively. And clinical experience has shown us that that is okay, that it works the same. I think the reason that this came about was because when we're doing directly observed therapy, there are times like the weekends when places are closed. So if the health department is closed on the weekend, then you can only do directly observed therapy for those 5 days a week. And we've seen that that is as effective. That is okay. One thing, and I'll point it out on the next slide, but one thing is if you are going to do 5 days a week therapy, it has to be directly observed, right? So you can't send a patient home with a script and have them take it 5 days a week, okay? If they're doing 5 days a week, it must be directly observed therapy because the idea is you're already cutting back on the days that you're taking it. So you need to observe to make sure that there's no other days missed. If they take it at home, because we're forgetful, people might forget a dose here and there, and then 5 days a week goes down to 4 days a week or 3 days a week, and that is not effective, and then resistance develops, okay? So 5 days a week is okay if it is directly observed therapy. Otherwise, 7 days a week. And we'll talk about the situations when you could have a patient not do directly observed therapy. Okay, so a couple things that I wanted to point out where I have it starred down here. The first one I already talked about with you guys. Okay, so when directly observed therapy is used, the drugs can be given 5 days a week instead of 7, so they can take the weekend off. Otherwise, they're given daily, right? 7 days a week. This second point here is really important. I'll mention it again when we talk about the individual drugs and their adverse drug effects. However, in addition to this 4-drug therapy, 4-drug and then 2-drug therapy that we're giving to treat the tuberculosis, a lot of patients are also going to be given pyridoxine. Pyridoxine is vitamin B6. So patients who are on isoniazid are at risk for peripheral neuropathy that's induced by vitamin B6 deficiency. Again, I'll talk about it more later, but just know that a lot of patients who are on isoniazid are also going to have to take a vitamin B6 supplement or pyridoxine. So the typical dose is 25 milligrams a day to 50 milligrams a day. So this is what we give to patients who are at risk for peripheral neuropathy. If they actually have it, we give them more. So who are these patients? So people who are taking isoniazid, who are pregnant, breastfeeding infants, patients with HIV, patients with diabetes, alcoholism, malnutrition, chronic renal failure, advanced age. Okay, that's a lot of patients in there. The diabetes, renal failure, advanced age, alcoholism, like that. This is really expanding our patient base. Any of those patients, while they're taking isoniazid, they need to be taking vitamin B6 or pyridoxine 25 to 50 milligrams daily. If your patient already has peripheral neuropathy, then they need to take a higher dose. They need to take 100 milligrams daily. Okay? Okay. So now we're going to talk about each of these 4 drugs that we use in tuberculosis more kind of specifically. We'll start with isoniazid. So isoniazid and rifampin are the most important tuberculosis drugs, right? These are the ones that we give continuously for the full 6 months. Or isoniazid is what we use for latent tuberculosis infection. The way that isoniazid works is by disrupting mycobacterial cell wall synthesis. The spectrum of activity for isoniazid is highly specific for Mycobacterium tuberculosis. Tuberculosis is really all we use isoniazid for. At really high concentrations, it can work against Mycobacterium kansasi, but that's really high concentrations. It's not like our best drug that we have. Most non-tuberculosis mycobacteria are resistant to isoniazid. So in general, really, isoniazid is an anti-tuberculosis drug. When we look at taking isoniazid, it is an oral drug. We take it by mouth, or we give it by mouth, and food impairs absorption. So especially high-fat meals. It should not be taken with a fatty meal. It's best if the isoniazid is taken on an empty stomach. That way, more of the drug gets absorbed. Isoniazid is a CYP inhibitor, so this can be important as far as drug interactions go. It inhibits, for example, 2C19. It inhibits some of the CYP3A enzymes. So there are a lot of possible drug interactions that can occur, because of its CYP inhibition. We see increased concentrations of drugs, when taken together with isoniazid. Adverse drug effects of isoniazid are very important to monitor for and keep an eye out for. The first one here is incredibly important, and this is hepatitis. So isoniazid has been associated with hepatitis, and if the isoniazid is continued after the hepatitis develops, it can be fatal, right? So this is huge to look out for. It is not something that we just ignore if it happens. So we do LFTs, liver function tests, at baseline. So when we start the patient, we check LFTs, and then we repeat LFTs if abnormal at baseline, right? Repeat if abnormal. If the patient is at high risk, then we repeat periodically. Or if the patient becomes symptomatic, then we repeat again, right? So we check at baseline to make sure that they're not already high, or that there's not already an issue. We repeat, if they're abnormal, we repeat regularly if the patient is at high risk, and then if you have a patient who happens to, end up developing symptoms, you would monitor again, you would check LFTs again. Most patients are at high risk, or most patients have at least some risk factors. So risk factors for developing hepatitis: age over 35, that's most patients. Consuming alcohol daily, so age over 35, alcohol daily. Concurrent use of rifampin. Well, you guys know that the recommended first-line therapy includes rifampin. So again, unless the patient's on some alternative therapy, then they're going to be, at least have that risk factor. And then again, of course, any patient who has any liver issues to begin with would be at an elevated risk. Another possible adverse drug effect that we mentioned previously is peripheral neuropathy. So this peripheral neuropathy that occurs with isoniazid occurs because of a pyridoxine deficiency, or vitamin B6 deficiency. So what we do to prevent this is, in any patient who is at risk, which we mentioned the risk factors previously, any patient who is at an increased risk for developing peripheral neuropathy receives daily supplementation of pyridoxine. So remember, 25 to 50 milligrams of pyridoxine daily to prevent this peripheral neuropathy. If the patient already has peripheral neuropathy, then we give an increased dose of pyridoxine of 100 milligrams daily, just to make sure we don't worsen their peripheral neuropathy that they already have. The neuropathy, if it is developing, it typically appears first as paresthesias of the hands and feet. Paresthesias of the hands and feet. So if the patients start to, tell you they're getting some numbness and tingling in their hands and their feet, that's an indication that they're probably deficient in pyridoxine, and that's starting to cause some peripheral neuropathy. Again, the way that we prevent this is just with daily supplementation of the pyridoxine. Convulsions are possible with isoniazid in patients who are prone to seizures. So if you have a patient who is epileptic, right? If your patient has epilepsy or some sort of seizure disorder, then isoniazid makes it more likely that they're going to have a worsening of that they're going to develop seizures. Hypersensitivity reactions are possible. Also keep in mind here, because isoniazid is a CYP inhibitor, a pretty potent CYP inhibitor, it can potentiate the adverse drug effects of other agents. So, this picture has phenytoin, but also carbamazepine, various other agents, their metabolism is inhibited by the isoniazid, so the agent builds up. And then whatever adverse drug effects that these agents cause, you have more of those happening. So that's important to keep in mind. Those drug interactions are important to keep in mind and monitor, and maybe decrease the dose of the other agent so that you're not having it build up and lead to toxicities. Okay, so now we'll move on to rifampin. Rifampin is included in a class of drug called rifamycins. Rifamycins include rifampin itself, rifabutin, which can be used instead of rifampin in tuberculosis in some specific situations, and rifapentine. So the rifamycins work by blocking RNA transcription in the bacterium. Rifampin happens to be the first line agent. This is the most commonly used first line agent for tuberculosis. The spectrum of activity of rifampin is wider or more broad than the spectrum of isoniazid. Remember, isoniazid was very specific for just tuberculosis. The rifamycins or rifampin has a more broad spectrum of activity. It is active against multiple different mycobacterial species. It's active obviously against the tuberculosis, Kansasi, which is the bacterium that isoniazid can work for at really high concentrations. Avium complex, lepre, etc. So wide spectrum against different mycobacteria. It can also be used against other types of bacteria, not just mycobacteria. For example, rifampin is used prophylactically post-exposure to meningitis that's caused by H. influenza or meningococci. So we can use it prophylactically, again, after meningitis prophylaxis. We're really focusing on the use of rifamycins in tuberculosis, specifically rifampin. Kinetics of rifampin. Rifampin, again, is an oral agent. All four of these drugs are orally given. Rifampin also has issues with CYP interactions. However, rifampin is a CYP inducer. So isoniazid inhibits enzymes. Rifampin induces enzymes. It actually is an autoinducer. So rifampin induces the metabolism of itself, which is okay. Like the way we have it dosed takes that into account. So you don't need to adjust the dose based on that. However, there are numerous other drug interactions that occur because of the fact that rifampin induces the metabolism of some drugs. Here you see a huge list of drugs that their metabolism is increased when the patient starts taking the rifampin. So things like warfarin, right? So if a patient is on warfarin and you give them rifampin, the warfarin is not going to be doing its job as well, and the patient is at risk for clots. Lots of other agents here, HIV protease inhibitors, so the HIV would not be treated as well. Methadone, which is a medication for pain or for opioid addiction. Oral contraceptives, that's a big one. If a patient's taking birth control and you give them rifampin, their birth control is no longer effective. That is not a good thing to find out the hard way. Lots of agents here, right? So what do? You can increase the dose of the drug, especially if it's something that you're able to monitor with a test or whatever. You can increase the dose, bit by bit, and you can run your tests to see, or take blood pressure or blood sugar or INR or whatever, just to make sure that your dose is good. or you can change the affected drug. So, maybe the patient is on propranolol, and you can change them to a different beta blocker whose metabolism is not affected by the rifampin. If the patient is on a specific agent and you can't change it, and it is not safe for whatever reason, this patient is not safe for you to be, adjusting doses or whatever, then you can change the rifampin. So rifampin can be changed to rifabutin in that specific situation. Okay, so if the drug interaction is so severe that and you can't change the other drug, you can't avoid it, then instead of rifampin, you could give rifabutin. Actually, I'll talk about adverse drug effects on the next slide. But one thing with rifampin is rifampin turns body secretions orange and red. So urine, feces, tears, these secretions all turn an orangish red color. So patients should be, told this, because that can be alarming. If your urine is, orange or red, you might be afraid that there's something wrong with the kidneys. So patients need to be warned because of that. And then also because of the tears, soft contact lenses can be stained. So patients should not wear soft contact lenses. Really, if they can just, wear their glasses, that avoids that issue completely altogether. Rifampin is relatively well tolerated. Adverse drug effects include nausea, vomiting, rash. Hepatitis is a possible adverse drug effect of rifampin. It's rare in terms of just the use of rifampin. Incidence of hepatitis increases when rifampin is being used with Isoniazid and Pyrazinamide, which when we're talking about tuberculosis treatment, it is being used together with the other agents. So it's kind of hard to tell which one is causing the hepatitis. Is it the Isoniazid or is it the rifampin? But especially when it's just rifampin, the incidence of hepatitis is rare. When we talk about hepatitis, just like we said with Isoniazid, the same stuff applies. We order LFTs at baseline. If they're abnormal, we repeat. If the patient is at high risk, then we repeat. So patients like older patients, alcoholics, chronic liver disease, those situations are situations where we would be more worried about hepatitis. If the patient becomes symptomatic, we would repeat LFTs, etc. So in most patients, this is okay, but we monitor LFTs just to make sure that there's no underlying hepatic issues that we're not aware of. We keep an eye out for any symptoms. If anything arises, we check immediately. But in most patients, this is going to be okay. Again, if the patient's older in age or an alcoholic, if they already have liver issues, then we would be, more cautious from the beginning, or depending on how severe the liver issues are, we might, go for an alternative treatment. Flu-like syndrome is also possible with rifampin. Flu-like syndrome is when patients experience flu-like symptoms, right? Like fever, chills, myalgias, like body aches. Now, this is more common when patients are at really high doses or get really high concentrations. So this is not common in the typical dosing regimen. Flu-like syndrome is more common in the intermittent high dose regimen. So instead of taking a lower dose daily, patients are getting really high doses with longer intervals in between. That's more likely to cause flu-like syndrome. Now, flu-like syndrome, if it does develop, this is problematic. It can progress to acute renal failure, to anemia, possibly shock. So it's not to be ignored or taken lightly. If patients, are developing these types of symptoms, then we do CBC to check blood counts, to check for anemia, etc. The other rifamycins, again, we said rifampin is the key first-line drug that we use for tuberculosis. But we do have other rifamycins that are effective against tuberculosis. Rifabutin is preferred in tuberculosis patients with HIV who have drug interactions with rifampin. Remember, rifampin is a drug inducer, and it induces the metabolism of some of our key drugs that we use in HIV. So if you have a patient who's co-infected with HIV and tuberculosis, we don't want to treat the tuberculosis at the cost of the HIV treatment. So instead of rifampin, we would just change the rifampin to rifabutin. Rifabutin is a less potent inducer of enzymes, so it doesn't have as severe interactions with the HIV drugs. So this would be preferred in these patients. Rifabutin does have some additional adverse drug effects, uveitis, skin hyperpigmentation, and then neutropenia. In terms of the neutropenia, we would monitor CBC in these patients. Rifampin, rifampin has some kind of kinetic differences. When we look at the half-life of rifampin, it is a very long half-life. So it can be dosed less frequently. We use rifampin in latent tuberculosis infection. This is, remember, when the person is infected with tuberculosis, but they don't have any active disease. There are no signs and symptoms present. So rifampin can be used along with Isoniazid for once weekly dosing. Remember, we said that traditional treatment is just Isoniazid daily for 9 months. But again, there are alternatives. If daily dosing is not possible, then we have other alternatives that we can give that allow for some more flexibility with dosing. This is one of them, Isoniazid plus rifampin once a week. For actual active tuberculosis infection, rifampin can replace rifampin in some select non-HIV patients who have minimal pulmonary tuberculosis. That's a really kind of select subset there. But that does allow you to replace the rifampin if rifampin is an issue in these very select patients. Pyrazinamide is, again, used in combination with the other agents. It's used with Isoniazid and with rifampin for tuberculosis. The mechanism of action of the pyrazinamide in tuberculosis is unknown, but we do see that most of the benefit is seen early in therapy. This is why we only use it for the first 2 months. It's not continued for the full therapy. Adverse drug effects of pyrazinamide include nausea, rash, joint ache. It can increase uric acid. However, it's typically not associated with gouty attacks. So it can cause some uric acid that we see in tests, but most patients don't actually develop a gouty attack. However, we do test uric acid at baseline, and then we can test patients if they do happen to become symptomatic. So caution in patients who have gout or are prone to gouty attacks. The pyrazinamide contributes to the liver toxicity that we see with the other agents. So we know that isoniazid can be potentially hepatotoxic. We know that rifampin can be potentially hepatotoxic. If we use both together, so again, we're concerned about hepatotoxicity. Pyrazinamide is added onto the bunch, and that does contribute or increase the likelihood of hepatotoxicity. So again, just like we said with the other two agents, monitoring is key. We monitor LFTs. At baseline, we repeat if they're abnormal, if the patient's at high risk, or if the patient becomes symptomatic. Ethambutol is, again, our kind of fourth agent that we use for the first 2 months of traditional pulmonary tuberculosis. The way that ethambutol works is by disrupting the mycobacterial cell wall. Ethambutol is used with the other agents for pulmonary tuberculosis pending culture and susceptibility. So we use all 4 agents for the first 8 weeks, for the first 2 months. But the actual recommendation is until we get culture and susceptibility back. If the tuberculosis is sensitive to the other 3 agents, if it comes back not resistant to anything, it comes back sensitive to isoniazid, rifampin, and pyrazinamide, then the ethambutol can be stopped. It does not have to be continued for that full 8 weeks. Now, the culture and sensitivity takes a long time to come back. Remember, the way that we test sensitivity is we take the bacterium and we put it in an environment that has that antibiotic, and we see, does it grow, right? Like, how much does this bacteria grow with the antibiotic compared to without the antibiotic? If it doesn't grow when the antibiotic is there, or if it dies when the antibiotic is there, then we know the antibiotic works, right? Well, remember, mycobacteria are very slow growing. Normally with other bacteria, we can, plate them and they'll grow quickly, right? A couple days and we're seeing growth. By a week, there is massive growth. That's because they replicate quick. Tuberculosis replicates very slowly. So it takes weeks and weeks for the bacteria to be able to grow, even without any antibiotic, right? So the point is that culture and sensitivity take a long time to come back with Mycobacterium tuberculosis. So it might be, 6 weeks before we get that culture and sensitivity back. So again, like the traditional recommendation is that we take all 4 of these drugs for 8 weeks, right? For 2 months. The culture and sensitivity, maybe you get that back at 7 weeks, right? If you get it back at 7 weeks and it's completely sensitive to those other 3 agents, then you can stop the ethambutol for that last week. You can stop it a week early, okay? So again, it doesn't necessarily have to be taken for the full 8 weeks. However, realize it's not going to be a week when you get your culture and sensitivity back, right? That the likelihood is that you might save 1 week, maybe 2 weeks of therapy, by stopping the ethambutol early. Okay, adverse drug effects of ethambutol. Ethambutol is not harmless, right? It does have adverse drug effects. So don't get me wrong, it is good if you're able to, stop it a few weeks early. That is a benefit. You don't want to continue it unnecessarily. The most important adverse drug effect of ethambutol is optic neuritis. It can cause issues with vision. Loss of, typically like what we see is loss of visual acuity, and a loss of red-green color discrimination. So the ability to tell the difference between red and green. So we check for this. We check for visual acuity and color discrimination at the start, so we know what our baseline is. The patient might not have great acuity to begin with, so we need to know where we're starting to know if it has gotten worse. And then we check this monthly, right? So on a monthly basis, we check to see if there's any decreases in acuity or decreases in the ability to tell the difference between red and green. If so, then we stop the agent. There's an increased risk of this when really high doses are given, and if there is a renal impairment. If there's renal impairment, then it's more likely that the drug will build up, and as the drug builds up, you get higher concentrations, and then that irritates the optic nerve, and you get optic neuritis. So important to keep an eye out for. And of course, all of this stuff like this, you guys, all these adverse drug effects, it's important to warn your patients about and counsel them. That way they know what to look out for, right? You might screen for something on a monthly basis, or you might, test, get labs on a monthly basis or every couple of weeks or whatever. But the patient might notice symptoms of this first. And frequently patients notice adverse drug effects or notice symptoms, but they might just think, oh, I'm getting older, or, I'm sick right now. Maybe this is just because of the tuberculosis, or they just ignore it for whatever reason. They don't want to be dramatic, or they don't want to be a pain or complain. But if you tell them ahead of time the specific things that they need to look out for, then they know if this comes up, I need to tell my doctor, right? This isn't just me being dramatic. This is a problem, right? So the only way they're going to know that is if you tell them. So counseling is important. The last thing is increased uric acid. So again, we test at baseline, and then we test if the patient is symptomatic. And same thing here with the Ethambutol. Caution in patients with gout, because this can precipitate a gouty attack. Last thing here, guys, this is just a really nice summary. Kind of has all of the information that we covered up here on the top. These are the 4 agents that are traditionally used for tuberculosis. And then you see all of the most important adverse drug effects, and then the specific recommendations or things that you need to do, all in one place. This is the same thing. This is just the alternative agents. So, again, like we mentioned, fluoroquinolones, we mentioned aminoglycosides, macrolides, etc. Okay. The top is the most important, though, because this is our first line that we go to. All right, guys, that is it for tuberculosis. Again, the one thing I want you guys to keep in mind is that this is traditional pulmonary tuberculosis in patients who are not HIV infected, where the tuberculosis is drug susceptible. There are all sorts of variations in tuberculosis treatment. So just, keep that in mind, that if it's resistant, or your patient has HIV, or your patient is pregnant, that's another one, then there are very specific guidelines for what you do in that instance. Okay, if you have any questions, go ahead and shoot me an email, and I will see you guys next week.